Alors bonjour, bienvenue, welcome to this lunch talk in the context of unleashing innovation, excellent healthcare for Canada that would propel us from our bad position in number 9 to moving up a little bit in the rating. So we have great speakers today. I'm delighted. Mon nom est Nathalie Desrosiers. I'm the Dean of the Common Law Section at the University of Ottawa. And it's a pleasure to be here today to replace Vice President Naylor, who is sick today, indication that we really need to improve our healthcare system. The lunch will be served outside in a little while after the speakers have had a chance to enlighten us, and then we can seek nourishment of a more physical time. So first, the way in which we're going to proceed, vous pouvez poser vos questions en français ou en anglais, mais les participants vont s'exprimer en anglais. We're going to hear from Dr. Naylor first for about 25 minutes, and then we'll have our commentators intervene in 5 punchy minutes each so that we can then move to a discussion. So let me welcome and thank Dr. Naylor for being here. I'm not going to read his entire biography. He's well known. He's a physician, a medical researcher, and he was the immediate past president of the University of Toronto, and he was a Rhodes Scholar. He was also, he served as chair of the National Advisory Committee on SARS and Public Health in 2003, a member of the panel that undertook the review of federal support for R&D in 2010 and 11. He's a fellow of the Royal Society of Canada and the Canadian Academy of Health Sciences, a foreign associate member of the U.S. Institute of Medicine, an officer of the Order of Canada. Évidemment, he has received many national and international awards for leadership in healthcare, research, public health, higher education. We are so delighted to have you with us, and we can't wait to hear about unleashing innovation. Merci beaucoup.
Thank you very much, Madame la Doyenne. Great pleasure to be here. I appreciate the generous introduction. And I'm looking forward to interchange afterwards, not only with this distinguished panel, but with the general audience. And I would say in that regard that I may seek the liberty of responding to the respondents, which is seems to be an academic tradition that I would like to avail myself of if necessary. Let me begin by just acknowledging that for about 12 months in 2014-15, I was part of a group of volunteers on a panel appointed by our health minister, National Health Minister, Ron Ambrose. The panel's report runs to 126 pages with appendices. It was released in mid-July. Some here will have had time to skim it. It is one of the best non-pharmaceutical soporifics yet created. And for those who haven't gone through it, let me make it clear, I will not be summarizing the report in its entirety. I'm going to hit a few highlights and try to ensure we have ample time for discussion. Now, listed on this slide, let's see if we can get this to go. No, it's not going. Oh, there we are. Here we have a list of the panel members. I'm not going to go through their bios. You can find them in the report. Suffice it to say, this was an outstanding group of individuals with whom I was privileged to work. And we were supported by a truly stellar secretariat in Health Canada. The members are all acknowledged in our final report, but I see Stephanie and Cajun are here. If they would raise their hands, they're hiding at the back. I don't know if Peggy Ainsley's daughter made it. Is Peggy? There she is. Peggy Ainsley was also a great contributor. Welcome, Peggy's daughter. Don't know your name. Lovely to see you. But suffice it to say that this was one of those tremendous team efforts, and I'm privileged to speak today on behalf of a terrific team. Many will know that we unexpectedly along the way lost a panel member. Professor Cy Frank of the University of Calgary, an outstanding healthcare leader and innovator, and a tragic loss for, obviously, his family and friends, for Alberta and for the country. And our report is dedicated to Cy's memory. The panel mandate shown on the screen is quite straightforward. We were asked in brief, what are the key themes or fronts for healthcare innovation in Canada? And how best can the federal government accelerate action on those fronts? Very straightforward. And a sort of 5-by-5 matrix was proposed to contain the number of themes and make this manageable. Now, chasing answers, the panel spent considerable time crisscrossing the country. We met with the healthcare stakeholders, one might expect. We met with provincial and territorial officials. We received and reviewed, with the help of the Secretariat, hundreds of submissions. And one thing I want to acknowledge right off the top is that we heard many very inspiring stories of local creativity and commitment and innovation. We were told repeatedly as well that stakeholders are frustrated with the status quo. And perhaps by way of briefly setting the context, let me share a few general conclusions that the panel reached about that status quo. First off, I think we all know that Canada has healthcare systems that are excellent in many ways and in many places. Countless citizens love their national Medicare program and their local expressions thereof. They see it as an indication of Canada's fair-mindedness and inclusiveness. They see it as a bolstering of social solidarity. We acknowledge all that. I think we all feel that. But the totality of evidence left us with little doubt that Medicare is aging badly. And on screen, you see one such piece of evidence from the totality of evidence we reviewed. The Commonwealth Fund will be known to, I suspect, most in the room. This is a highly regarded and impartial think tank based out of New York, well known for its observations of international healthcare systems. And their 2014 report card, examining 11 national healthcare systems among some of the wealthier OECD nations, put Canada squarely in 10th place. In fact, there was no particular metric on which we did very well. Only the U.S. was behind us overall, and at the rate our American friends are moving forward in this era of Obamacare, it is not inconceivable that if things don't change, we may find ourselves firmly in last place in a few years. Now, second point, I think, that has been driven home repeatedly in recent weeks, healthcare across the OECD is changing. It's changing in response, first and foremost, to continued aging of populations, though Europe is well ahead of us in that regard. But it's also changing in response to the revolution in information technology and unprecedented advances in medical science. Many stakeholders in our travels told us that Canada was not ready to respond to these trends and these challenges, and we concluded, rather regretfully, that they were right. We are not well prepared. A third general observation was that Canada has truly excellent healthcare providers, but it became plain that in the current context with its poorly integrated healthcare systems, professionals often struggle to deliver the high-quality healthcare that Canadians deserve, and in many cases, their full scope of skills is simply not employed efficiently and effectively. Now, on a related point, the panel was informed that, notwithstanding lack of incentives, there have been many, and this is very sluggish. There we are. The panel was informed that, notwithstanding all the local energy we saw poured into innovation, all the local creativity, there's been a persistent problem with scaling up effective projects. And we learned time after time that these projects, which had an impressive local impact, had not been scaled provincially, let alone nationally. This is a pattern that led a former health minister known to all at the University of Ottawa, Monique Bégin, and her co-authors to call Canada a nation of perpetual pilot projects in healthcare, a tag that continues to stick for good reason. Now, let's see if we can make this work. Good. A fifth observation that I think is very germane to our discussion is that provinces and territories have been making real progress in cost containment. And many other nations similarly have cut the rate of growth of healthcare spending since 2009. However, it is clear that Canada does deserve some credit for having done better than many of its OECD peers. But if you examine this slide, you can see that our spending patterns are somewhat oddly asymmetric. And just have a glance here at if this will work. Let's see if we can make it work. No, we can't. We're going to toss this remote right now. But if you just glance down this column, you'll see the OECD ranking is unusually asymmetric. Look at the bottom two rows, and you'll see on physician expenditure and drug expenditure per capita, we are very much near the top of the league table. And on other areas, we are relatively low, not least on hospital spending per capita. The other thing that's notable is that while our spending now is moving up more slowly than other nations, we are still well above the overall OECD average. You combine this with an economy that is still sputtering, and you have a rather worrisome situation. And I would add that while the provinces are still chipping away at healthcare reforms, they continue to be under enormous pressure to deal first and foremost with frontline issues, the crises of the day. As so often happens in administration, what is urgent and immediate is crowding out what is important for the longer term. Now, I think it's fair to acknowledge that starting in 2012, some fine work was done under the auspices of the Provincial and Territorial Healthcare Innovation Working Group. Laterally, however, I think most observers feel that that effort has lost momentum. I think the hard reality that's emerged is that the provinces lack catalytic funding and in some cases a critical mass of expertise to make the substantial changes needed to advance their healthcare systems and modernize them. With that, let's turn, if we can, to the federal role. Now, recent polling data certainly suggests that the majority of Canadians no longer are convinced that more money is the primary answer to our healthcare challenges. And despite that, we've seen a lot of focus in this election on the level of transfers from the federal government to provinces and territories. You can see a graphic history of those transfers on the screen, and I think you'll see immediately there's no firm baseline. Now, we've not gone back to the 1950s, but that's when we had 50-50 cost sharing for national hospital insurance. That disappeared relatively early once we had universal medical services insurance, as you can see. And down we've come and then come back up rather more slowly. There is no obvious baseline here. There's nothing to be said constitutes a gold standard or reference point. Now, I think, again, this audience will know that in 2011, the Conservative government announced that starting in fiscal 2017, a pre-existing 6% annual escalator in healthcare transfers to the provinces would fall to 3% per annum or the level of GDP growth, whichever was larger. And there's an obvious dilemma, I think, that one can see there. A 6% compounded growth rate in the current economic circumstances is rather hard to sustain and will squeeze other federal priorities. But at the same time, population aging and novel technologies will make, in all likelihood, healthcare costs very difficult to sustain for certain of the provinces. And you put these together and you have, I think, a very serious dilemma. Well, the arguments about transfers are continuing. I think we should not forget that something else very important happened in 2011. At the same time the growth formula changed, the federal government stood down any intent of imposing conditions on its transfers except compliance with the Canada Health Act. And in the same vein, it later allowed the Martin-era health accord simply to expire in 2014. And one might ask why, and I think we all have some sense of that. By sending money with very few strings attached, Mr. Harper's government could finally say to Canadians with some clarity and real conviction, don't complain to us about your health care problems. Talk to your premier or your provincial health minister. Now, it's easy to criticize the government for that step, but let's recognize that healthcare cost sharing has been a recurrent headache and flashpoint for successive federal governments. Conditional spending power has turned into a fair bit of spending and not much power. In fact, Ottawa found itself years ago with shared responsibility for the performance of healthcare systems, but with limited authority to drive change and recurrent cash calls. So this is not an old problem, but this government's response represents a definitive disentanglement. And this probably explains why, if you look back, that once the recession of the 1990s eased and cash came back into federal coffers, and once the federal government began re-escalating healthcare spending, Ottawa worked hard to find some new models of federal-provincial accords to promote collaboration and innovation. And you can see a quick scan of some of these initiatives on the slide. Some had a really large price tag. And unfortunately, I think the verdict of history is that these earmarked monies all flowed on a formulaic basis, all more or less the same as usual transfers, Some were directed enough to have specific effects, particularly on areas of wait times. But the reality is that mostly these monies have reinforced the status quo. And the other reality is this is what the provinces wanted. Now, what other models exist? Oops. There we are. Good. Again, here in the nation's capital, many will be familiar with the so-called C agencies, which embody a different approach. These are collaborative entities operating arm's length from the federal government, and they really have had a pretty substantial record of working effectively with provinces and territories, as well as a wide variety of stakeholders. And you'll see familiar names on the screen, such as the Canadian Partnership Against Cancer, the Mental Health Commission of Canada, CIHI, InfoWay, the Canadian Patient Safety Institute, and the Canadian Foundation for Healthcare Improvement. All these agencies, of course, are primarily funded by the federal government, sometimes with modest provincial contributions. They're small, but I think the general view is that many of them punch well above their weight. And because they do operate at arm's length, it has proven easier for them to develop these collaborative links and to move projects forward with provinces and territories. So for the panel, as we looked at this gridlock, this puzzle, we had to put some pieces together. One piece was the prevailing sense that neither traditional transfers nor formulaic funding models had driven meaningful reforms. Another piece, that there were many promising pilot projects, too many, that had languished locally. A third piece was a recurrent challenge across the country with designing, implementing, evaluating, and scaling new delivery models. And a final piece was a number of federal agencies, credible, working effectively with stakeholders in provinces and territories, but working in overlapping fields such as healthcare information, healthcare quality improvement, and patient safety. If you examine that, it was predictable, I think, that many stakeholders did advocate in their submissions that the panel should support the creation of some type of arm's length or neutral innovation center. This is an innovation Switzerland, if you will. And a center of that nature could, in theory, support new delivery models. It could accelerate the scaling up of best practices and policies across the country. And it could certainly get a flying start on its mandate if some of the existing agencies with overlapping missions were rolled together to get it going, and that would be cost-saving. Many submissions to the panel also strongly urged what we might now call, falling on this analogy, a Swiss bank account, a national innovation fund, specifically earmarked to promote sustainable change and to help break the gridlock. One WAG said it would be table stakes that the federal government wanted to get back in action and work with the provinces and territory. And as I think many will know, that is exactly what we recommended. An innovation fund that would be focused on supporting sustainable and systemic changes in the delivery of health services to Canadians, a fund that would give provinces and territories a bit of wiggle room to make reforms to their systems, and that would also put working capital on the table for stakeholders to assess and scale up promising innovations. And I would emphasize that the report envisaged that these funds would not flow on a formulaic basis. They would instead be directed to coalitions of the willing, jurisdictions, institutions, providers, patients, industry, committed innovators of all backgrounds. Quite a different model than the previous health accords. I do want to emphasize we are also clear about the need for caution in implementing this fund. Any monies would have to be deployed very efficiently and carefully, with rigorous selection criteria and milestones. We also envisaged a gradual ramp up towards a target budget of $1 billion per annum, and that would only occur if performance parameters were met. Now, what's the reference point? Canada spends about $220 billion a year on healthcare. We spend a modest amount on research. We spend a smaller amount still per capita on what might be called development, and we actually spend very little indeed on turning R&D into value-generating innovation in healthcare. And frankly, it's no wonder in that situation that we have a problem with innovation in general and with healthcare innovation in particular. Now, you may still question a target spend of $1 billion per year. Another piece of quick calibration: take out the debt servicing costs, and the Government of Canada in the 2015 budget spent $265 billion on programs and people. $1 billion is less than 0.5% of that amount. And to repeat, it was set as a medium-term target if milestones were met and if fiscal circumstances permitted. Now, the budget for a new innovation centre would also come from the same fund, but it would be limited to avoid excess overheads. As I've already hinted, this agency, in our view, would draw staff from the Canadian Foundation for Healthcare Improvement, the Canadian Patient Safety Institute, and after a transition period for completion of existing projects, Canada Health in Poway. By consolidating their mandates, it would serve as a centre of integrating expertise, focused again on sustainable improvements to healthcare delivery. And I do want to emphasize that we envisage that agency employees would not simply sit and preside here in Ottawa. They would be expected to get out in the field and to work alongside innovators in a range of projects. This model, I should emphasize, drew not only on stakeholder input, it was also based on some international reviews and visits. You can think of it as an amalgam of various international and domestic precedents and projects, not least the Center for Medicare and Medicaid Innovation in the U.S. Federal Administration, which is on quite a remarkable tear in terms of moving delivery reforms forward in the U.S. I would add that just days after we released our report, two major British healthcare think tanks independently proposed an innovation fund for the United Kingdom with a population-weighted scale very similar to ours and many of the same aspirations. Now, on screen here are the 5 themes or fronts for action identified by the panel. I'm going to go quickly because none of these are particularly startling. We've known for years, I would argue, much of what needs to be done in the areas where action is needed to improve Canada's healthcare systems, which is why I think much of the interest in the report after the fact focused on the question of federal engagement, whether the federal government did want to come back to the table. So in the interest of time, I'm going to do what amounts to a flyover of just the 3 of 5 themes in the report highlighted on screen. You can think of these as priority areas for action on the front lines, with or without catalysis from the federal side. So let's start with the people we're meant to serve. And this is an obvious top area for focus. We have had an awful lot of rhetoric about patient-centered care for many years, and the reality is rather far removed from that rhetoric. I think engaging and empowering patients is intuitively appealing as a reform theme for all the obvious reasons. There is now a growing body of international work suggesting that such strategies can indeed have positive impacts on costs and outcomes. You won't find a lot of randomized trials for the obvious reasons, but a lot of impressive quasi-experimental designs. We also, in our travels, heard about many exciting initiatives of this nature across the country, and we felt it makes very good sense now to proceed with careful evaluation and scaling up of those domestic efforts, as well as to adapt from international experience. And this would happen on 3 levels: individual, organizational, and system-wide. And here, I have to say, as a starting point for individual patient engagement, it seems intuitively obvious that every adult Canadian should have access, ready access, to the core elements of their own health records. And I don't think we can make progress with shared care or virtual care if our patients are viewed as anxious nincompoops and subject to confiscatory charges when low-quality photocopies are made of the health records, whose very creation was funded in the first instance by taxpayers. Now, I earlier flagged the panel's concern with integrated budgets and the impact of the strange governance of Canadian healthcare on professional scopes of practice. What we see internationally time and again is that integration drives innovation and facilitates it. That's especially true as regards team-based models of care and better use of information technology. It also drives cost effectiveness. We saw that fully a quarter of a century ago in the RAND health insurance experiment, one of the few large-scale randomized studies of health policy change. In that study, costs were about 25% lower per capita for patients enrolled in a staff model health maintenance organization, or HMO, as compared to those in fee-for-service practice with various levels of copayment. Now, this audience will be familiar with the ongoing and excellent work done by many modern nonprofit HMOs in the U.S. Some have evolved into substantial integrated delivery systems. Noteworthy exemplars would be Kaiser Permanente and Intermountain Health. But what I think may be less obvious is that the major payment reforms occurring under Obamacare all aim at promoting integration through bundled payment and shared provider accountabilities. You can think of them as steps along the road to fully integrated delivery systems. Now, in Canada, we've been talking about integrated delivery systems for more than 20 years. Today, we see finally a few baby steps being taken towards bundled payment reforms in some jurisdictions, but frankly, lack of integration of governance and budgets remains the single fatal flaw in Canadian healthcare, in my view. Promoting these forms of payment and changes in governance was a major concern for the panel, and we felt strongly that an innovation fund and innovation center could facilitate these moves in collaboration with provinces and territories that were willing to take those steps. And it's hard to imagine anything more important than amalgamating budgets and rewarding professionals in ways that let them work to the full scope of their competence and creativity. These are reforms that are particularly pertinent to multidisciplinary mental health services where we have access problems. They're also pertinent to rehabilitative care for seniors, another area where we lag and where demographics has created an imperative. But integration is also essential to improve First Nations and Inuit health services. And those who've read the report will know that many of our recommendations were directed to improving the deplorably disintegrated state of healthcare for Canada's Aboriginal peoples. Now, integrated delivery systems have a further advantage. They have the scale to do serious innovation in information systems. And in the same vein, they have both the authority and motivation, including financial motivation, to link different services and to use information aggressively for management. That's not the case for most care in Canada. It's certainly not the case for primary care as currently organized, as these four rather depressing snapshots show on the screen. In fact, despite considerable efforts by Canada Health Infoway, we are still well behind many peer nations on a range of dimensions of health information technology deployment. And a particular challenge with the graying of the population is our failure to advance mobile information technology and nanosensors. These are technologies that could enable a new era of virtual care and patient monitoring. And in a period when we have growth in chronic diseases and an aging population, these also can facilitate care at home and allow seniors to live longer and with greater dignity and independence. Given how far behind we were, the panel had, in this context, to make some practical recommendations to close gaps. You'll see some on screen while trying to catalyze leapfrog developments. We envisaged a short-term continuation of Infoway with bridge funding that would enable it to complete its current projects, call it a catch-up phase, if you will. But thereafter, as the agenda shifted from infrastructure or backbones to uptake and applications, call that cognitive behavioral therapy, if you will, Infoway would merge into the new innovation agency. Now, you will also note in this section that we coupled precision medicine and information technology, and you may wonder why. The rationale is that it's become increasingly clear that the emerging field of precision medicine is very dependent on enhanced use of information technology. And I want to take just a second to talk about precision medicine. This is a catchphrase of sorts, a grab bag term. But the trend in terminology embodies, obviously, what is a widespread move to characterize patients more precisely using biomarkers and information technology. It implies further the use of biotechnology to design and choose more or less bespoke treatments for subgroups and even individuals based on those characterizations. This is potentially a boon because today's medicine of averages is inherently inefficient and often unsafe. The number of patients you treat to prevent one adverse event are often very high, and side effects are incurred by all those treated. We're fortunate, of course, that the drive for evidence-based healthcare began here in Canada, and that its epidemiological rigor has helped all the professions to sharpen our diagnostic and therapeutic aim. But much of the time, despite efforts to individuate care, current interventions are based on studies that, if you will pardon a graphic metaphor, involve firing therapeutic shotguns at crowds and comparing the results of blanks and live ammunition. Now, that said, well, I think this is a huge revolution brewing in clinical care. Some healthy skepticism about biotechnology is warranted. It's a fast-breaking area. Industry is pushing very hard and has its own agenda. There are many unanswered questions. And all this explains why in a great many jurisdictions across the world, governments have taken steps to channel this big wave of advances to ensure that the benefits are maximized and the potential harms, including misallocation of resources, are minimized. Canada, in contrast, and yet again, has no plan. There is no federal or national strategy, which is why we urged a coordinated national effort to think through the implications and applications of the ongoing revolution in clinical biotechnology. Now, as I said earlier, oops, this is a very interesting thing. Has it died?
This is the end.
I know I'm going backwards, Patrick.
Yeah, go back
there
okay.
we are.
Okay,
come back to life.
That's good.
As I said earlier, time does not permit me to delve into the fourth and fifth themes of the report. Perhaps I can touch on them in the discussion, but I want to sum up. I think we would all agree that Canada's healthcare systems are a source of national pride and that the professionals working in these systems continue to provide essential services valued by millions of Canadians every week. Nonetheless, there are some unhappy facts. The scope of public coverage in this country is narrow. Our inadequate coverage of pharmaceuticals and our weak procurement and price control strategies for drugs need to be urgently addressed. Our underutilization of the full range of health professions is indefensible, and particularly a problem with an aging population. Meanwhile, our costs remain well above the OECD average, and our overall performance by international standards is at best middling. All those concerns become more acute as you look out over the next 10 to 15 years. This is a period in which baby boomers will retire in droves, dependency ratios will shift and squeeze tax revenues, and advances in biomedical and information technologies will seriously disrupt our time-honored healthcare delivery patterns. There is, I think, relatively little doubt about some of what urgently needs doing. The issue is, how can we get on with it? And that is why the panel concluded there was a pressing need for renewed interjurisdictional collaboration to modernize Canada's healthcare systems. Ours is a somewhat subscale jurisdiction, and trying to move reforms forward in even smaller scale subnational jurisdictions is a challenge. And so it was with hopes of breaking the current gridlock that we recommended a model for federal engagement that would be built on prudent investment through an innovation fund and catalysis through a major center of excellence in healthcare improvement. We felt we also needed a new ethos of partnership among the provinces, territories, stakeholders, and Ottawa. And we needed a shared commitment across jurisdictions to scale existing innovations and make fundamental changes in incentives, culture, accountabilities, and not least information systems. We believed then, and I think all panelists continue to believe, these were practical recommendations that would move Canada's healthcare systems forward, and we felt that concerted action on them could make a meaningful difference across Canada within 10 or so years. But there's another issue, of course. That may be what we need to do, may not be what we need to do, but will we get on with anything? So let me close accordingly with a word on the Harper government's response to our report. I've seen it argued that the attempted burial was based on specific concerns about money and machinery. I understand that argument, but I think it's superficial and frankly a bit naive. As I said earlier, Medicare has been a political thicket for this government and its predecessors alike. I've heard more than a few senior Liberals muse about the virtues of federal disentanglement. And we concluded after careful consideration that it was nonetheless very much in the long-term public interest for Ottawa to re-engage seriously with healthcare issues across Canada. This signal had been sent in 2011. It was time now to change the channel. On the other hand, for Mr. Harper and his colleagues, changing the channel would mean a serious policy shift. It would mire them again in Medicare mud wrestling with the provinces and territories. And it would be particularly tough to explain such a volte-face in the throes of an election campaign. So in many ways, it is understandable that the report did not meet with a very happy reception. In contrast, it's pretty clear that the other two parties are committed to re-engaging with the provinces and territories in a serious way. If the polls are to be believed, and I never really believe them myself, it's certainly possible that those parties, together or separately, will be leading the country forward, and certainly likely the two of them together will hold a majority of seats. So perhaps it would be appropriate in the question period to spend a little time discussing their proposals and platforms, which are both similar and different in some interesting ways. With that, let me just reiterate what a pleasure it is to be part of this speaker series. I look forward to interacting with you and with the distinguished panelists, and I thank you for your kind attention.
Merci beaucoup, Dr. Naylor. So I'm going to invite our panelists to join us one by one. First, we'll hear from Professor Patrick Fafard, who will focus on federal-provincial relationships. His PhD is from Queen's University, and he taught at the School of Policy Studies from 1995 to 1998. But before coming to University of Ottawa, he served as Director General of Strategic Policy and Research at the Intergovernmental Affairs Secretariat of the Privy Council, and was also in senior positions in Saskatchewan, Alberta, and Ontario. So he's well placed to talk about federal-provincial wranglings. So, Professor.
Merci beaucoup. This is one of the first events for the recently created Center for Health Law, Policy, and Ethics. So I want to acknowledge that and invite you to follow our activities as they unfold. Let me start by offering a word of thanks and congratulations to Dr. Naylor and his committee. Long ago and far away, I was executive director of something called the Fight Commission, and about 2 weeks before we issued our report, I was hauled into the Premier's office and basically told, we're not going to say very much when your report is released. My heart sank. And then I realized that, in fact, no, it was going to. They had a strategy for how they were going to respond, but at least they had a strategy. I'm not quite sure if the Harper government has a strategy other than let's not think about it. The other thing I wanted to acknowledge right off the top was that the Naylor report is about health services delivery, not so much about health. And the report quite nicely acknowledges this and talks about the fact that if the government of Canada wanted to have a really big impact on health, it would be through its spending on social and other programs, because, of course, the things that determine our health are not the healthcare services we receive, but rather levels of education, levels of inequality, levels of quality of housing, things like that. So they quite nicely acknowledged that and then moved on. So what I want to do is offer a couple of comments from the perspective of someone who toiled in the trenches of intergovernmental relations for a number of years. And to begin, one can't not like the main recommendation. Who can be against innovation? Who can be against scaling up innovation? Who can be against ending the plethora of pilot projects? These are all very laudable goals. And, I mean, I think they're very, very, very important. Nor do I have any particular problem with the mechanism. Anyone who's followed the Canadian Foundation for Healthcare Improvement, and God knows members of my family have worked there in the past. And they've done really good work, and they're very small, and they punched above their weight. I think that's true. The Canadian Patient Safety Institute, somewhat smaller, much less well known, but also does incredibly important work as sort of creating benchmarks and fostering conversations that might not otherwise have happened. The problem, of course, is that right here, right now, healthcare innovation doesn't roll off the tongue during an election campaign quite as nicely as, I don't know, more doctors or cheaper prescription drugs or, heaven forbid, the legalization of marijuana. It's not a publicly accessible concept. In a way, the report is written not so much for the public as it is for people inside the healthcare system. And that's all good. And at some broad level, I think that the recommendations, if implemented, would be a very good thing. What concerns me is Dr. Naylor talked about a renewed interjurisdictional collaboration, and I don't see a lot of evidence that the report has a theory of how, in fact, to promote interjurisdictional collaboration as much as it has collaboration as between stakeholders. What do I mean by that? If you work in a provincial government and official Ottawa does stuff, sometimes it feels like Ottawa is reaching behind, around, underneath the provincial government and engaging directly with stakeholders in the province, which at some level is not a bad thing, particularly if it's a very small province. But what that has the effect of doing is potentially distorting provincial priorities. So let me make this very concrete. The government of Saskatchewan, for good or for ill, has chosen over the last decade, particularly the last 5 or 6 years, to invest quite a bit of money on surgical wait times, and has done not a bad job of reducing wait times for surgery and diagnostic imaging. In so doing, it has put less priority on other things, like, say, for example, electronic health records. My concern is, in a report like this, if the agency, if it were to be created, were to say, we have a request here from the Saskatoon Regional Health Authority to do something really cool on electronic health records, great, who can be against that? Except it may or may not be consistent with the overall priorities of the province, which you might say is not a bad thing, except if these innovations, when they're brought up to scale, are to be sustainable, inevitably it's going to mean, dear province, we got some money from the feds, we've demonstrated the bona fides of this innovation, we would now like to put it in the A base, please. And again, it's not a bad thing, except it may not be the priority of the day of the government. Which isn't to say it's not a good thing, it just means it's not the priority. So that's my worry. How do you get around that worry? It seems to me that the rollout of the agency, when it's done, you would want to do it in such a way that there was some degree of collaboration or at least transparency with provincial governments. So let me give you an example of the worst way to do this. When you work in a provincial government, sometimes monies flow from various bits of Health Canada, and you don't know about it until after the fact, and they've got this wonderful report, and they've got all this evidence that they've done this cool thing, and then they come knocking on your door. That's supremely irritating. But if it was done in a way that says, hi, we've got this request from a bunch of jurisdictions in your province or in 2 or 3 provinces, and we're thinking of funding X. What do you think? At a minimum, that transparency lowers the temperature. At a maximum, it might allow for the provincial government to say, well, let me guess, you probably got 3 or 4. Go ahead and fund one, but we would prefer this one over that one. It's your decision, but, right? Because what you want to avoid is a world in which the good things that the agency does become a bit of a political football. What does this mean? This requires, in addition to the innovations that Dr. Naylor and his colleagues recommend, in parallel, we have to have a rejuvenation of intergovernmental relations in this country, and I don't have time to go into that now, but it requires a degree of transparency and conversation as between the federal and provincial governments, which does not exist now. At a very micro level, one agency that didn't get much discussed in the report is the Canadian Partnership Against Cancer. And I haven't studied closely, but whatever they've done and however they've done it, there's a lot of innovation in cancer care in this country, spearheaded by CPAC, but done in a way that has, for some reason that I can't quite figure out yet, hasn't elicited that kind of pushback or the defensiveness on the part of provincial governments. And so there may be some clues there as to how we would do that. So I'll stop there. Thank you.
Okay, merci. James? Maintenant, j'aimerais inviter la professeure Karen Eltis, who will focus a little bit on her remarks on the recommendations relating to genetic discrimination in electronic health records. Professor Eltis is a professor at the Faculty of Law, Civil Law section, and she has a long experience in writing beautiful things in law and technology and healthcare. So merci beaucoup, Karen.
Merci beaucoup, Madame la Doyenne, pour la belle introduction. It's my great pleasure to be here, and I, too, would like to commend the chair, Dr. Naylor, for a particularly edifying report despite a very, very difficult mandate. Especially enlightening to my mind is the comparative aperçu. For those who know me, I am a comparativist. But the comparative aspect housed within the report, I think, is especially helpful, and I would like to invite policymakers to focus on that particular section or sections. Specifically, I think examining the successes, failures, or somewhere in between of other jurisdictions' respective approaches in greater depth will allow us as Canadians to develop informed parameters for rethinking the normative framework relevant to innovation in healthcare. So I think, yes, undisputably, we are behind. But rather than rushing forward, I think the report does well to examine what other jurisdictions have done. And in light of time constraints, I was told this is 5 minutes. I've probably eaten up 4 just now. But I will look at 2 specific issues: genetic discrimination that the report addresses, and EHRs, electronic health records, very broadly, and talk about what I like to call, with an eye towards informed or more cautious unleashing of innovation. So in terms of genetic discrimination, this is addressed of course, in the report, talking about proposing regulatory and legislative amendments, such as changes to several pieces of legislation, including the Canadian Human Rights Act. I've done work and have written a comparative report for the Canadian Human Rights Commission on point. And I think, first of all, it needs to be mentioned that genetic discrimination is of particular concern to already vulnerable groups, gender groups, ethnic groups. This has been mentioned by very many, and many are especially concerned about the stigma attaching beyond the employment and insurance framework. So what can we do? What must we do? In the report, I examined a few jurisdictions and looked at what they have done and how they might, their example might serve Canadians. And yes, of course, a piece of legislation, and of course there is one that's pending, has tremendous symbolic value of reassurance to groups that face this potential discrimination. But on the other hand, and I think this comes from my own work on comparative research and the work of others, is that one needs to be especially careful and perhaps even forego hasty or rush narrowly tailored specific anti-discrimination statutes. I can talk about the experience of a few jurisdictions. I won't, given the time frame. I'm only mentioning one. I am on sabbatical, but will be spending it in Israel. And that's one of the first jurisdictions, if not the first, that did adopt specific anti-discrimination statutes because of certain populations' disproportionate predisposition to certain ailments that have genetic aspects. They are now sitting down and reworking these pieces of legislation that seem to cause a lot more complexity than initially intended. Many unintended results. We talk about perpetual pilot projects. I think my caution would be, in terms of genetic legislation, if we are talking about specific legislation or specific amendments, not to be brought into that trap that several jurisdictions have faced. Back to the drawing board, back to the drawing board, back to the drawing board. In fact, several European jurisdictions have chosen to house sunset clauses within their anti-discrimination genetic statutes because, of course, and this has been said so many times, I cringe when I say it, but science is going to evolve so much more quickly than law. So one has to be very cautious, precise definitions. Most of the jurisdictions that have reworked or are reworking their specific genetic statutes because of the inadvertent side effects of these, the definitions were either too broad, too narrow, and most importantly, and I think in terms of genetics, I think this is what we want to underscore, these pieces of legislation did not examine the tensions between individual and group rights, not realizing that genetics goes beyond individual, goes beyond the family. Simple example, the way one statute was written, doctors can't disclose results to minor children, so they have to go around that. The doctors can't speak to the parents. All these inadvertent, difficult byproducts. So individual rights, genetic discrimination goes beyond that, so we need to look at intersectionality. And the other aspect that needs to be explored, and this was done well in Australia, so I would invite the Australian example to be examined more closely, complementarity between specific genetic anti-discrimination statutes and the like, and of course in Canada there's a federal provincial aspect with employment and insurance, but complementarity with the existing privacy normative framework. In my other life I deal with internet privacy law, and there's an important interaction that must be examined between the privacy statutes, privacy framework that we do have that itself is being revisited, and any changes to the genetic discrimination framework. Patient empowerment. I think, just to flag 2 more issues, There is important case law in Canada on perceived disability in the genetic context, and I think that needs to be further explored, and individuals need to be made aware of this as employers. Finally, one issue that needs to be addressed and may be addressed through legislation, but also through other ways, and comparative inquiry is important here. DTCs, direct-to-consumer testing. Some of you may or may not know. Of course, you know, the more popular aspect is that this is the Google founder's wife who has direct genetic testing to your home for about $99. This has yet to be properly regulated. The German experience is instructive here. They focused on the requirements of the test providers, but paid little attention to the quality of the products being sold. Back to the drawing board. Okay. So seeing as how I don't have a watch, I'll quickly move on to, yes, the electronic health records. Informed unleashing, I think the main issue is how to shift from, and I quote, the past medical model, of the 15-minute face-to-face clinician-patient interaction towards, and again, this is a quote, the concept of population health and wellness support in place 365 days a year, 24/7. So we can think, of course, of telemedicine. The American example that's mentioned in the report, I think it's important to look at the difficulties that have arisen in the American context through the Obama program. Rivalries between tech firms. This is a big subject in the United States. The hospitals use third parties for electronic health records, and these third parties are companies that have tremendous rivalries, so they actually block information rather than facilitating information. They block information deliberately, block electronic exchange of information, to the creation of what Miller, an economist, has called in the New York Times, the government-subsidized creation of information silos. Right? So we have to be very careful of accountability and undue reliance on third parties and the like. We talked about the great talent, the MDs in this country. In the States, many are complaining that there is a third person in the exam room. I remember going to my pediatrician's office with my kids, and the poor man who has about 30 years of experience is struggling as he's typing, and suddenly all the attention is gone, and to the point where the New York Times was recently writing about how many hospitals are advertising as they recruit physicians, do not worry, there will not be any EHRs. So this is not to say, as the dean said, who can be opposed to innovation? Quite the contrary. But I think what has happened in the U.S. context, where information was cut and pasted by physicians who are not yet comfortable with the EHR, leading to increased error, that needs to simply be examined. And rather than relying on the American experience, or perhaps relying on the American experience as a warning onto us for certain aspects, I think in France they have the DMP, the Dossier Médical Personnel, which has somewhat of a different approach and is worth fleshing out, looking at in greater detail as well, where patients through this system are allowed to take greater responsibility for their own health care, thereby tying into the promotion of patient literacy and empowerment that is so eloquently set out in the report. So I will put the brakes on at this point, and thank you for your attention. Thank you.
Now, finalement, I'd like to call Jeffrey Simpson, who's the Globe and Mail National Affairs columnist. He has won all 3 of Canada's leading literary prize. He does not need an introduction in this crowd, but simply to say that certainly he is not only a member of the University of Ottawa board, but he has contributed tremendously in all of his 8 books, the latest one being obviously Chronic Condition, Why Canada's Healthcare System Needs to be Dragged into the 21st Century. So he's ideal to comment on this. Monsieur Simpson.
Merci, Madame la Doyenne, Mesdames et Messieurs. You just mentioned that I was a member of the university board, so I'm very delighted that this center has been created, because completely ineffectually, I keep saying at meetings, universities have to concentrate on where they have comparative advantages, which is very hard because universities want to be all things to all people. And I've often said the University of Ottawa has 2. One, it's its bilingualism, and the second is it's in the nation's capital, and it should be focused on public affairs, public policy, and so health is central. So je vous donne mes félicitations, tous qui ont organisé le centre. Secondly, it's a pleasure to be with David Naylor. He won't remember either of these, but I went to see him some years ago, before I was doing the book Chronic Condition, And I said, Mr. President, he was president of the University of Toronto, sitting there at Simcoe Hall, I said, look, you're perfectly positioned as the former Dean of Medicine and now President of the University of Toronto to make the case, which is so obvious in the statistics, that health is eating everything alive, including university budgets. And people will listen to you if you say that. And he sat back there in his little wry way, and he said, let me understand what you're suggesting. You want me to get into a big, now I'm going to use his words, he won't like, you want me to get into a big pissing match with those people over there. This was the provincial government in the buildings. You want me to get into a real slanging match with my huge health sciences area of the university, and you want me to spit in the teeth of public opinion. No thanks. I knew he was a wise man. Then I went to see him when I was doing chronic condition, and he gave me a lot of good advice, which leads me to the first point about the report, which is that I thought the diagnosis of what ails the healthcare system was by and large very, very strong, partly because it mirrored my own, or maybe I stole the ideas from David when we were chatting in his office. I can't remember. But I thought the problématique was extremely strong, and therefore it had a high educative value. Secondly, I find myself, because this is my last election campaign and I've been doing what I've been doing for 40 years and it's time very soon to stop, sort of running the great risk of saying all the time, I've seen all this before. And so when I read this report, I had a real sense of, I've seen all this before. But there's something more fundamental here. David usefully put up that list, you may remember, of various federal initiatives over, gotta go back to 1992. But that list could have been extended back another 30 years. And federal governments of whatever political persuasion have had this irresistible itch up until the Harper government, and I'll come to that in just a moment, to be seen to be doing things in healthcare. Because the public always identifies it as the number one issue of concern, and because they see it as a national issue. It's a national icon. It's a national symbol. It's not a Prince Edward Island symbol or an Alberta symbol. It's national. And therefore, federal governments have been irresistibly drawn to the proposition that they should, quote unquote, do something about healthcare. But David said something extremely wise, just en passant, which is that the problem in the healthcare system, and I think he was speaking about the provincial level, is the disjuncture between the budgeting and the accountability. But nowhere is that larger than in federal-provincial relations, where the federal government expends huge amounts of money, and outside Native people and the military, doesn't actually deliver anything, except through those small agencies he mentioned. So this report suggests that the federal government get re-engaged by spending up to $1 billion without any capacity to actually implement the spending of the money. So now you're back in exactly the same problem that's plagued all these governments over all these years. And I'm not sure that's a very wise thing to do, even though the goal is worthy. Secondly, there's a tremendous, because the healthcare system has no magic solutions and because it's so complicated and so variated, there's a great temptation to kind of take a lot of money and throw it against the wall, hoping that parts of it will stick. I remember when Bob Bell, who you would know so well, did a presentation at a conference I was at, and he filled up an entire screen with arrows and priorities, and there were 60-some odd of them. And I stood up, again, I guess because I've been around too long, and I said, any organization that has 60 priorities has none. Tell me the 3 priorities, and we can talk about them. We can have an argument about which the 3 or 4 should be, but not 60. So this report has too many priorities, too many arrows going out into different directions. If I had been the curmudgeon on the committee, I would have said, if we're going to spend $1 billion, let's not get lured by this idea of innovation. And we can do stuff about systems technology and how doctors are paid and system integration, all of which is very worthy. But when you break it down, how much money have you actually got for each of those different areas? Pretty small amounts for very large objectives. So I might have been inclined to come at the analysis the other way and say, what's the most important single pressing priority on the system? And let's go at that with our $1 billion innovation fund. So you can have a discussion about this. For me, it is the aging of the population, which is pressing down. We're doing ce qu'on appelle en français un rattrapage. We should have known 20 years ago, 15, 10 years ago, that the demographics were the demographics. And now everywhere I go in the country, and I speak to lots of healthcare groups, fortunately they still invite me, what's the number one thing on their minds? How are we going to deal with the seniors, the aging, the chronic disease management, the rearranging of scopes of practice to deal with the aging of the population? Ça, c'est, pour moi, là, la priorité principale auquel tous nos gouvernements vont faire face et font face maintenant. So I would have taken this and I would have said, because after all, what David and his group did, they were asked to recommend ways to promote immigration in the system without spending any more money, which was an impossible mandate. I wouldn't have sat on such a committee because it was so farfelu. But it illustrates this old federal itch to be seen to be doing something. And since the Conservatives wouldn't want to do anything actively themselves, they said, maybe they can tell us how to innovate in the system without us spending any money. Well, of course the report died because they didn't want to spend any more money. I'm not saying that was right or wrong. And here comes a report saying spend up to $1 billion. Well, of course they're not going to pay any attention to it. So interestingly enough, the place I think where this report now has resonance, because it came too late for the opposition parties, is in the Federal Department of Health, where civil servants are always looking for ways to exercise federal jurisdiction. That's what they're there for. And the conversations that I've had indicate they're really interested in this report. So here's my last prediction in the last 30 seconds. The new government will come in. They haven't paid any attention to this report because it came too late. And they're looking for vote winners. And by the way, you're not going to win any votes, as Patrick said, by saying, elect us and we're going to innovate in healthcare. No. So they've talked about home care, they've talked about seniors and all this stuff. So health department, if they were smart civil servants, would take this report, look at the platforms of the parties and say, you know, Minister, there's this report here that says we should spend more money. You've said we should spend more money. These are your priorities. They're not quite the same as this, but can't we marry the two together? Can't we have some scheme by way we're going to try to innovate in the areas that you said you'd like to spend some money? In which case, I think this report has a fighting chance. Thanks.
Dr. Naylor has asked for time to say a rebuttal.
Not a rebuttal.
Yeah, 4 minutes.
What a fantastic set of interventions, and I'm going to be quite telegraphic in responding. My main response is to thank the three panelists for very thoughtful comments. For Patrick, I would simply say that the critical thing about the mechanism is that we did consider how CMMI was functioning, and there, in many cases, when they work at the state level through Medicaid rather than Medicare, the precondition is that the state signs on to scale and fund something that passes evaluation. So we anticipated very much your concern that you have to have the provinces involved. The advantage of having the stakeholders is to kind of get this energy up and to begin to capitalize on the local creativity we saw. But obviously, you know, if you don't have some sense of a scalability with provincial and territorial buy-in, you just multiply the pilot projects. So very much on the same page, and I think that is a very thoughtful point of emphasis that any rollout, if this were to happen, has to be meticulously positioned with the provinces and territories for all the obvious reasons. So on side. If I turn to the question of genetic discrimination, what a thoughtful set of comments. Thank you. This was not an area where we really, I think, dug heavily into the literature. And I hope we are clear in that we're not calling for some rapid response that could backfire, as you suggest so thoughtfully. So I would certainly on that front highlight our concern simply that we get ahead of what is already happening on the front lines of care and begin to respond. And I have no issue whatsoever there. I do, however, want to take a second to acknowledge the question of subsidized silo building, because frankly, that's what Canada has done for years. I had the happy experience of being Dean of Medicine and Vice Provost for Healthcare when all the Toronto hospitals were busy procuring unique information systems, which at the time I called a set of electronic or digital moats and silos being constructed to prevent mergers and amalgamations and to ensure that they could all go on happily. So this is not a U.S. problem. However, I think that the challenge for us nationally will be to find some commonality and interoperability of records, certainly at the provincial and territorial level. The provincial interoperability is secondary. And we're still a long way from that, which is quite embarrassing. And I agree, by the way, fully that to use something like the French dossier model and to have the patient at the center of the control of the records is critical. I want to bundle the comments about CPAC with Jeffrey's strong response. And I have to acknowledge that, Jeffrey, you feel a little jaded in this one in your response. Maybe I'm unduly optimistic, but I think if you examine the mechanism, we are not going back to the table with billions of dollars to be passed out formulaically. We're talking about trying to have catalysis, which means you do not need to get into massive transfer type strategies. And if you think about CPAC, the example that was given, what you see is that with catalytic action, particularly in a specialized area where there's already a fair bit of solidarity across the country, you can move the needle. And I for one, although I think the question of what the priorities should be is left deliberately open in the report. But for one, I would say, where do you start? I think you start with integration and information, because they both come back to the question of patient-centeredness. And I believe personally, if you think about just how much value we've had out of initiatives like the Canadian Foundation for Healthcare Improvement with a pittance of a budget, if you think about the experience with CMMI in the U.S., which has had a major impact very quickly, I think that in an atmosphere where there is a real crying need for innovation and where many of the provinces and territories are struggling to make change, I think that this type of catalysis, and especially if you had 2 or 3 provinces forming a coalition to drive reforms, I think you could actually make quite a dent. So I hear the criticism. I respect it as coming from someone who has huge mileage and great wisdom, but I remain quite optimistic. And let me, in that point, just say, on something like population aging, that's simply a demographic bellwether for a broader set of issues. You know, it's a tremendous pointy end of a spear if you want to get focused on the need to move to community care and home care, if you want to get focused on virtual care and home monitoring and so on. But those issues are generalizable. The whole system is too focused on doctors and institutions at all levels. That's why we have a problem with mental health services. So I do think that while aging is a big priority, it really is a demographic slice that's simply a kind of wonderful biopsy of a system that is not aging well. Last point of optimism. Actually, the opposition parties have looked at the report. It came out early enough so that elements were considered in both platforms. I refuse to comment on any platforms at all. I'll probably have something to say about them at some point. But if you examine, for example, the scale of the money being invested by the Liberals, completely consistent with the scale-up size of the Innovation Fund, and they're talking about coming back to the table to see what they would do at a health accord, but clearly caution about going with the 6% escalator. Some of the pharmacare material, including the focus on improved prescribing and procurement, as well as the question of evaluation and regulation. Some of that is really quite closely mirroring the report. There's mention of precision medicine in the Liberal report as well. And I could go through and pick out one thing after another. And I happen to know that there was some active cherry picking of the report by both opposition parties. So I do think it had an impact there. The bigger question is, what will the long-term impact be? Here, let me close simply by saying, you know, when you write these reports, you sometimes find that you hit a very nice sweet spot. SARS was a classic, where we had a country that was scared, We had some international embarrassment from how we responded. We had 3 to 4 months to get that together. We had a majority government, and very rapid action was taken by the Martin government to implement the work of a commission appointed by Mr. Chrétien. And that was about as fast as I've seen anything go. Having done this for 25 years, provincially, nationally, internationally, I have become quite philosophical about the fact that many of these things find their way in bits and pieces into public policy over time. And although I never really agreed with much else she did, I did like it when Margaret Thatcher said she was very patient, provided she got her own way in the end. And in public policy, I think we all have to be very patient. Thank you.
Merci. Est-ce qu'il y a, ça serait le temps pour les questions de la salle ou les questions de... if you people from the audience, why don't I invite our panelists back on, and I can monitor the questions from here. You should go and speak to the mic if you don't mind, so that we can register your questions. We are being filmed, and it's going to be available to the general public, obviously. Yes. Okay. Maybe identify yourself and...
Sure. Michael Wolfson from the university. Well, first, it's an excellent report, so I really appreciate it. I agree with David Naylor's response to Jeffrey Simpson. I wouldn't put aging as such a panic thing. It's a harbinger, or it's a signal that something's going on. But as one of your neat tables shows in the report, the thing that's driving costs is not the population aging, it's technology, it's salaries, other things like that. My question with regard to the report is, I was intrigued to see the emphasis on precision medicine. And the report does say that these things need to be evaluated, but is this not perhaps a deeper concern, because it could turn out to be a huge cost driver for the system?
Do you want to take that?
Okay. We're doing that. It's the Tonight Show. It's great.
Yes, that's true.
Thank you, Michael. The precision medicine area is moving extremely fast, and skepticism is warranted, I think, because when the human genome was sequenced in 2001, there was huge hype, and most of us who'd been around research for a while knew it was going nowhere for quite some time until they figured out what to do with the information and elaborated hugely on it. We're now in an incredible phase of elaboration, and having cynically watched health research proclaim a new dawn about 25 times in a long career, this is the first time I've actually seen something really dramatic breaking very quickly that could transform healthcare. So I think we have to get ahead of it, and I think you're right to flag costs as well as harms, because you start fiddling with stem cells, who knows whether you're going to end up with malignancies. You start fiddling with the immune system and immunotherapy, who knows what trouble you'll unleash. So it's this is very powerful technology that has huge implications, including ethical, as we begin to re-engineer human beings. You can imagine in utero manipulation on a grand scale. Some of the new CRISPR technology allows you to actually modify the genome on the fly, which I'm sure there'll be a Nobel Prize for that one in the next 3 to 5 years. But it's also unsettling to consider its implications. I worry that we don't know fully what TPP has done in terms of biologicals. And in general, the pharmaceutical industry continues to price discriminate and use rebates as a way to begin to work around some of these collective bargaining efforts by jurisdictions. At some juncture, I think the major OECD nations, G8, G7, whomever, need to get together and have some type of collective strategy for dealing with pharmaceuticals and biologicals. Because I do think these biologicals are going to be hugely and heavily priced, and people will pay a lot for what they offer. And we have to have a strategy that makes this safe and affordable for all Canadians.
Hello, Neil Errol from the Faculty of Law. You also mentioned CRISPR. That's I'm a PhD candidate in the Faculty of Law. You mentioned CRISPR. That's also a part of my research about the legal aspects of human genetic modification. But my question is, continuing the thread that you just raised now about constraining the cost. First of all, who can object to investment in healthcare innovation? So, of course, not me. But the point is that I wanted to ask you, what do you suggest as a model to govern intellectual property rights, and in particular, in respect to patenting of innovation that might come out of this fund, patenting of new pharmaceuticals, medical devices, and so forth, so that, of course, the general public can enjoy the fruits of this innovation in an affordable manner?
Thank you for the question. I would certainly not imagine that the Innovation Fund, as imagined by the panel, would be doing a lot of research that would lead to patents. In fact, I would hope that it doesn't actually... Pardon me?
Yeah, that's not its meant.
I would hope it doesn't do something that would be called research, but evaluation, because we have CIHR, we have other agencies. The goal here is to get downstream and deal with scaling, evaluation, and a rapid cycle reapplication of insights to improve the healthcare system. So the devices will be landing, and I could see that there is a risk, and it'll have to be watched if this were ever to happen, where you had, say, a medical device manufacturer saying, why don't we roll this out, we'll subsidize the device and get an evaluation for marketing purposes per passu. So you're going to have to dance through all those potential thickets anytime you play with industry. But I think in general the focus is on better practices, better policies, better regulation, appropriate scaling, so that you can begin to move the system forward and apply what we already know. In that sense, I wouldn't foresee a lot of IP issues. At least I hope there would not be many, and they should be manageable.
Hi, good afternoon. Ivy Bourgeot with the Telfer School of Management here at the University of Ottawa. Thank you so much. I wanted to comment a bit on what Mr. Simpson had mentioned about having many priorities and some of the issues that were mentioned in the report. I wanted to highlight one in particular of bundled payments. We've had numerous conversations around the issue of bundled payments with the Canadian Academy of Health Sciences report, and thank you so much for highlighting that. And I'm wondering also, just kind of bridging to Patrick's comment about, I can't imagine, perhaps I'm more cynical or negative, I can't imagine a province wanting to foray into the politics of bundled payments. This is not low-hanging fruit. This is right at the top of the tree. But perhaps the experience that we're having right now in Ontario with the tensions around the agreement between the province and the OMA is instructive in that regard. So I was curious about your comments about that.
I will say first off that I hear and understand and appreciate the concerns, but I don't think bundled payment is top of the tree. There's already bundled payment initiatives that have been rolled out in Ontario, and considerable debate about how to include physicians in bundled payment along with other health professionals. So
can you just, for the benefit of the, just explain a little bit more what bundled payments
So bundled payment says rather than paying for the 15-minute encounter, you're paying for care across the continuum. The ultimate bundled payment would be you have a capitation fee that provides comprehensive care, may include pharmaceuticals, certainly includes a range of professional services, hospitalization, and so on for an individual in an American HMO or integrated delivery systems. And as you go back along the spectrum and you pick up snippets, you get, for example, a bundled payment plan that says, okay, we'll give the hospital a budget for someone to have a hip replacement that will pay for all the services, including the professionals, doctor, you're included, and we'll track you out to rehabilitation and on to outcomes. And by the way, the final payment will be bonus if the outcomes are good. Radical shift on the surface of it. On the other hand, when you look at how fee-for-service is unfolding, and the sort of gridlock we're seeing, particularly in Ontario, I am reading and hearing that, well, doctors are very angry. More than a few have also said, isn't it time we moved away from this impossible gridlock? I am conflicted. I was the mediator for the first stage of those negotiations, as you may know, so I can't talk about what was on the table. Justice Winkler was the conciliator in the second stage after Lisa Purdy and I tried to bring the sides together. I think you can read Warren Winkler's report and get a sense that he believed that this system was broken. And I would add that a week from now I'm coming back to town to talk to the provincial medical bargaining groups. And my message to them is, I can tell you right now, going to be quite direct. We can't go on this way. Hundreds and thousands of items in a fee schedule, no reward for value, only for volume, no reward for innovation, no reward for teamwork, no ability to delegate to a more cost-effective provider and to work as quarterback of a team, or even as, the center. Heaven help you, doctor. You may not be quite as smart as you think you are. Mm-hmm. None of that is feasible under the current system. So I, for one, believe we have to move in this direction for the future of the health profession. And with a kid who's a psychiatry resident, I have a vested interest beyond the professional.
Thank you. Anybody wants to respond to you haven't had a chance to respond to the response.
Just to make a quick comment on, Ivy's right. What I worry about is a world in which the Government of Canada, through this fund, funds some project on, I don't know, scope of practice. And a bunch of willing actors in a given province magically transcend years of rancor. And that's all great, except in the adjacent province or regional health authority, it may not; those conditions may not exist. And so I often wonder, so who is going to be left with the difficult task of pushing the reform? So the current debates in Ontario about how we pay doctors are a really good example. It's hard work. And no amount of pump priming, if you will, by the federal government or an agency of the federal government can get around the fact that at some point there's got to be that really hard work. And just to end on a more positive note, it is the role of the Government of Canada, however, to strategically create incentives where a provincial government can isolate itself from the hurly-burly and say either the feds made us do it or the feds gave us incentive to do it or whatever. Because at some point, as we see with the doctors, you need, as a provincial government, to be able to push back. So, but if it's done in partnership, I think it can be very powerful. But at the end of the day, there's got to be some hard work on the ground done, and that I think we should never lose sight of.
I would just say that recommendation sort of underscored my concerns. The federal government has no capacity to dictate the scope of practice not dictate, but even influence these sorts of CBA negotiations. This is provincial jurisdiction, this is labor law, this is the administration of the healthcare system by the provinces at its costing. So this is overreach. We can have views in the federal government about it, but we don't have the capacity seriously to influence it. It's a bit like one of the political parties is promising this in this election campaign, the hiring of an unspecified number of additional doctors. And I'm saying, what can the federal government, even if that was a good idea, which I think it isn't, but even if it were a good idea, how could the federal government influence this? They don't train the doctors, they don't run the medical schools. I suppose they could turn over a lump sum payment conditional upon you spending it for more spaces in your medical schools. But again, the federal government has no capacity to affect the outcome of the training. So I'm very cautious, I'm sorry, maybe I'm jaded, about the federal government being invited to involve itself through the money it has or the money it puts on the table in something over which it doesn't have the capacity to deliver.
So first off, let's agree that both platforms, but particularly the New Democratic Party platform, is skating into provincial jurisdiction in a pretty serious way. If you read the report, I think you don't see a sense that someone's going to dictate bundled payment to provinces or tell them how to conduct their negotiations. On the other hand, I can tell you we had provincial officials from more than one province, and not all small provinces, say if we had a national pay commission operating with evidence, if we actually examined scopes of practice, if we considered cost-effective provision, that might avoid some of the leapfrogging and whipsawing, and that might be useful. And again, there's a difference between the federal government, which has many people wanting to pick its pocket and many enemies at any time, no matter who's in power, and where influence is often more important than particular power, including spending power, and the reality that there are national entities. So there's a national consortium of licensing bodies. Mm-hmm. There are discussions there that are very important. If you had something arm's length from Health Canada, if you had an agency that could work with that type of national body, work with the Royal College of Physicians and Surgeons, work with the national healthcare associations, I think a lot of this dialogue can be moved along. And just to say finally, if no one wants to do bundled payments, the response of the agency would be, no sale. Mm-hmm. And we'd probably say, and thank you, Jeffrey, now we have one less priority to worry about, so we can focus more.
And this will be my last comment. I see the dynamic of, because I've had the opportunity to be in 8 provinces and many of them many times at healthcare conferences since my Instant Rare book came out. And the two takeaways I would say is, one is there's a lot of hard thinking going on in all kinds of areas of the healthcare system about how to make it better, because they know that the years of trying to make it better by throwing a great deal of additional money at it are over. Yeah. So now there's hard thinking going on. And the conferences that I'm asked to attend, I actually don't just speak, I listen. And this is the message I'm getting back from everywhere. So this is encouraging. Secondly, I think the provinces are up against it fiscally. And they see their healthcare budget. I'm not being, I forget your nice word, Michael, panicking about it. But I was just in New Brunswick, where 19% of their population is over 65, and within 10 years it's going to be over 30%. That's driving them to have serious worries about every single aspect of how they deliver health care. Do they have the money for it? Do they have the physicians for it? Do they have the facilities for it? That's set to the scope of practice. I mean, this is a major preoccupation with a lot of the provinces. So, as a consequence, I detect the second is we're now willing to get down off our high constitutional horse and talk among ourselves and even go to the federal government and say, can you help us in the following areas? Get our ducks together here. We can't have 10 priorities, but can we have 1 or 2? And go to the federal government and say, we really need your help. And it's in that way, I think, you're going to get the federal government to be more constructively involved than this way, which is, to my respectful critique, too much of this but too little of everything.
Est-ce qu'il y a d'autres questions? Any other questions? Is the lunch arrived as well? Or?
The lunch has arrived.
Well, that's so. Any further comments from the panelists? Well, then I can release you and you can have lunch. You've sung for your lunch and you certainly have entertained us. On your behalf, I want to merci beaucoup. Thank you very much. Actually, great to discuss this report.